First and foremost, I want to thank you people for availing yourself this morning. I can see the group is increasing. I want to also appreciate ISN for having educated me this far. And of course, for the contribution ISN has given to us as Kenya Renal Association. I did my nephrology at the Stellenbosch University and Tigerberg Teaching Hospital with Matthew and others, and Alazin Davids and Rafik Musa, persons I respect so much. And this morning, I want to engage you briefly on what has happened to us during the COVID-19 pandemic and the influence this has had within the transplant landscape. I've got no interest to declare. The company that brought me here, sponsored me here, has no interest in transplantation whatsoever. So I'm free. We know much more now on COVID-19 than we did last year but one. I will not go to the details because we know the science of COVID-19, but I want you to appreciate that acute kidney injury is at the center of this pandemic, and patients who get acute kidney injury within this COVID-19 story will often have poor outcomes, and this poor outcome is related to the need for vasopressors, mechanical ventilation, and often they will die. And that patients with CKD, end-stage kidney disease, transplantation, and indeed those who have got glomerular diseases, perhaps because of the treatments they receive, may be at increased risk for infection and associated morbidity and mortality. Now, this slide, I saw it with Professor Mark Rigel, and of course, is a common slide for those who have been reading. It really tells you the various pathophysiological mechanisms under which kidneys suffer in COVID-19. Center to this, of course, is a cytokine storm. Patients or kidneys getting acute kidney injury from ATN, interstitial nephritis. And interestingly, we have observed, or it's in literature, that persons who get various glomerulonephropathies and that high-risk APOL1 gene is again one of the things that's being mentioned. And like Jonathan Walla said yesterday, in days to come, we may see a lot of CKD related to this COVID-19. Now, when COVID-19 came calling, we know what happened. And this acute kidney injury treatment, of course, was in a mess. A lot of risks, a lot of challenges, issues to do with access to care, resources, drugs, and all that. And the world learned how to go around this. And that's why perhaps I'd say that the outcomes are more predictable than they were last year but one. But then we understand much more on acute kidney injury, but we don't know too much on CKD. The only thing we know for real is that people who have got acute CKD are likely to get chronic kidney. People who have got chronic kidney disease are likely to get AKI related to COVID-19. Now, the data on or among patients with CKD and end-stage kidney disease is really scarce. But again, like I said earlier, these long COVID survivors or the long COVID patients are going to have huge risks of progression of their disease. And we must always remember that kidney injury is going to be common acutely and chronically, and we must aggressively look out for kidney disease in these persons. Work has been done out there, and this literature is now available. I'm sharing with you a slide which demonstrates or which shows a study which looked at outcomes among patients hospitalized with COVID-19 who either had CKD and end-stage renal disease and and those ones who are normal. In these patients, one can clearly see that the normal patients, or those ones who didn't have CKD, being as reference, were obviously advantaged. But when you come to patients who had CKD, then one sees something very interesting. Whereas many of us have been thinking that people who have got end-stage kidney disease and on dialysis are likely to die, then this study reports something different. And it says that patients with end-stage kidney disease appeared in this study to have better outcomes than those with non-dialysis CKD. Of course, there are issues to argue here. But this study, of course, is not one study that one can quote and say it's generalized, but it's something for us to think about. Perhaps, again, one would imagine that patients who have got end-stage kidney disease may have maybe less cytokine storm and may be able to then survive through this. And this is observed by the fact that they had lower C-reactive protein levels at admission, one of the markers of inflammation. This is just one of the things to think about. We may not have our own local data, but again, as individuals, we have participated in managing patients with CKD and COVID, and we know our feelings about this. But this tells you more the controversies that exist on this. Now, what about in kidney transplantation? What have we learned? One of the things that we now know is that presentation of COVID-19 in transplant recipients appears to be similar to that in patients who are not immunosuppressed. Small studies again here and there, but we know that the mortality rate is between 20 and 30%. But again, it's still difficult to conclude whether kidney transplant recipients are at an increased risk of death from COVID-19. And again, personally, I've participated in managing quite a number of patients who have had transplant in COVID-19, and many of them have survived. Again, looking into the literature, this very interesting article in JASN tells us that these patients who are likely to die are the ones who have various comorbidities, and asthma, chronic pulmonary disease, among others, have been shown to be independent risks for death among patients who have got COVID-19 and have been post-transplanted. Now, we looked at our literature at Kenyatta National Hospital, and we are still ongoing into understanding our patients. Of the 300 patients we have been following up, 24 patients, unfortunately, got COVID-19. The mean age for that is, as you can see there, 48 years. The median is around 48, with the other statistics as shown there. Again, doesn't deviate much from what we know, that males were more likely to get COVID-19. Only 3 patients died. This is not very impressive data in terms of size and numbers, and we didn't do sub-analysis because of the amount of data. But again, this is still works in progress, and we shall be reporting to you our observations. But the message is we are still having our patients getting COVID. Males are more likely to come to us, but the mortality may not be as high, and the fear that we had before may not be as warranted. Now, because of these fears and deaths and all that, the world then sat back and said, do we transplant these persons or not? But then an advisory came in, and this is what is now being practiced, that there is need to be a balance between the benefit of transplantation for individual patients and the risks of nosocomial COVID-19 spread for both recipient and donor. In other words, we must not expose these patients to COVID-19. They must not come to hospitals and get COVID-19 in hospitals. Again, there has been this push for individualized decision based on scoring tools. Now we have got tools that can assist you to score and assess the benefit of transplantation against not transplanting. And these are tools that perhaps we want to look into so that we make rational decisions on transplantation. Of course, the general measures of transplantation, the general measures of trying to contain COVID-19 will apply. But the fact that we need to social distance and all that has pushed deliberately our patients away. We don't want them to come, we want them to stay. And this, among others, has seen a reduction of transplantation rates in the world. Telemedicine, like the one we have been practicing at KNH, from Berkeley, both video and telephone telephonically has been very helpful, and most of the world has embraced that right now. And this, again, has been very helpful. But again, there has been considerable barriers to telehealth access, and particularly for the low middle income economies, this has not been available, and this has brought out of inequities to transplantation. But when clinically appropriate, this is a way to go. Defer and don't do a lot of laboratory testings, or those which will make your patient come. And for renal biopsy, I don't think there's a time you want to do a lot of renal biopsies. But again, this is not the time to even think about rejection, which would make you want to do a biopsy, because management of this can be very, very tricky at this time. Management of COVID-19 protocols have changed over time. A lot of diversity is here and there, and individualization of care. But importantly is that the world has learned that this story of immunosuppression is not the way we used to know it, and we can comfortably now manipulate immunosuppression. Sometimes we even go off completely immunosuppression, and for the number of patients I've taken care of, sometimes they have even come out better in terms of their renal function than they were before, perhaps because of the robust use of steroids and stuff like that. So the point is, we are not as fearful as we were when joking around with this immunosuppression. At the end of the time, we want the patients to live. Now, generally, within all this matrix, many people will reduce immunosuppression, the net immunosuppression, importantly targeting the antimetabolites, and again, depending on the disease situation, come down on the CNI. For another issue in management is about now whether to treat patients as outpatients or inpatients. Of course, these are decisions that are made within programs. Now, the European Association of Urology, in its contribution towards management of transplantation in the world, has come up with risk management guidelines. But again, central to this again is the abilities of institutions to handle transplantation. They have come up with three priority groups: the low priority patients who will be deferred, or you can postpone transplantation for 6 months, provided there is no harm. Then you have got the high priority and emergency category who needs transplantation, and in between you have got the intermediate category. Now, this one, coupled with the simulated tools I mentioned earlier, would be a better guide for people, practitioners of transplantation, to think about in trying to offer transplantation. So basically, we have observed a reduced uptake of transplantation all over the world, and this has been because of scarcity of hospital resources, limited testing abilities and capacities. Some institutions still cannot do the SARS-CoV-2 PCR testings. We do not understand. Sometimes we have got problems with the sensitivities. Many other times we wanted to do a transplant, then we tested the patient. Yesterday, the patient was negative. Today, we test the patient is positive. All these uncertainties has contributed into us slowing down. And of course, those outcome concerns I mentioned earlier of who will live and who will die. Then comes in the ethical issues of transplantation. Again, this has been challenging, but have not yet been addressed. For example, how ethical is it to keep someone on the list because they live with people who are at high risk for spreading COVID-19? It means that persons who live in settlement areas, because of the crowding and all that, may be pushed off, and then the most affluent people who are able to stay 1 acre away from each other will get transplantation. These are ethical issues. Is it ethical for hospitals to suppress transplant volumes to maintain ICU beds in anticipation for additional future of COVID-19 resource burden? Because often with transplant patients, they get very sick, they go to ICU, they block a bed. So people then would say, oh, wait a minute, transplantation is not that serious. So how ethical is that? How ethical is that we deny patient transplantation when you know that it's life-saving, so that we can save others? So these are ethical issues that need to be tackled, and the world is still out there looking for solutions for this. Stock and others have recently commented in Transplantation Journal, and this is what they are saying. Programmatic decisions about transplantation will weigh more heavily on distributive justice, beneficence and non-maleficence, than respect for autonomy. Who benefits more and others without harming them is what we are saying. Ethical issues here, which needs to be addressed, and indeed very, very important. In conclusion, ladies and gentlemen, COVID-19 has adversely affected the landscape of global transplantation, and there's been a need to change protocols during the pandemic. Equity and access to kidney transplantation has been influenced by economics and has adversely affected the low middle income countries like ourselves. Vaccine equity has been a major challenge. We've been pushing and pushing. Our transplant patients must get vaccines and all that, and we all know the story of vaccines. The influence of the pandemic in ethical and unethical practice is a thing we need to every day consider. These challenges exist and need to be addressed. And as you know, transplantation science is evolving and it's still works in progress, and let's see what happens. Asanteni sana. Thank you very much.